does that support the level of savings that you're expecting?
I guess I would say this scrutiny report that's here isn't a scrutiny report on outcomes-based commissioning, and to some extent we're straying into a different agenda item. So perhaps when we have a discussion around work programmes, we could have a discussion around the broader outcomes-based commissioning and have something specific on that. We'd be happy to answer your questions, but that isn't the scrutiny report that's sitting in front of you. It's one around the BCF tonight.
Just say we'd welcome that. Unfortunately, it was on the agenda and is no longer. And I think it's important that we do bring that does come to scrutiny.
I was just going to come back on that really and say the difficulty is this report sets out that nationally there has to be a strategy for the implementation of by 2020. And what I think as a committee we're just trying to get a grasp of where we're at. And I hear that we're doing better than many others. As colleagues have said, I think we're putting a lot of eggs in the OBC basket, and I think what we're all struggling this evening is to find out how we're aiming to get to that target, which is pertinent to this report. Is the idea that at the moment OBC is over 65s? Is the idea that as that develops, it will go further down the age stream? That's what we're trying to grasp at the moment. I don't know if my colleagues concur.
I mean, this isn't a report around integration or ABC. It's a report around what we're doing in relation to BCF. So I'm just trying to keep us in the facts that are in front of us here. If we are able to crack what we're doing for the over 65s, we will have transformed how we work together. And we know that some of the biggest pressures on our joint system between health and social care is dealing with people over 65, people with long-term conditions, particularly over 65 as they become more complex. We know the issues that we've talked about around dementia, and those challenges also become sharper in the over 65. So that's why we're focusing on doing that, transforming that piece of work as a very firm stepping stone to be able to help us transform a big piece of work at one time, and then obviously it would be very sensible for us as a system to stand back, reflect how far we've got, and then see where the next phase takes us.
Darren, no? Any other questions? Okay. Actually, I think I did have one. I'd found it and I think I've lost it. Yeah, this is still on the risk log really, and so that's page 41. So it's 5.4, and obviously this is what obviously we keep coming back to, and this was in relation to the CCG's 5-year financial improvement plan, which obviously has changed somewhat in the last few months. I think just really how confident are we that, that risk is being addressed, and that, we can be confident that that will, that we'll be able to achieve what we want to achieve despite the financial situation.
This risk originally arose because the implementation of BCF resulted, because of the national formula for it, resulted in a significant cost pressure to the CCG, which was in excess of £3 million, which went straight to our bottom line. And this really relates to actually whether or not the CCG can continue to fund the BCF at that level. Now, I don't know if you recall, but at the last meeting we looked at some of the CCG's response to special measures and how it was going about looking at how it could reduce expenditure. One of the areas that we had considered was whether or not we reduce funding to the BCF, and we concluded at that point that joint schemes between the CCG and the local authority focused on improving outcomes, reducing admissions, as the foundations to outcomes-based commissioning actually was a very important priority. We're still of that view, but clearly moving forward, depending on the financial planning requirements on the CCG, we'll have to keep everything under review.
Okay, thank you. So if no one else has got any questions on this item, we'll pick up the conclusions and recommendations at the end of the meeting, and we'll move on to agenda item 8, which is Paula and Stephen again. Did you want to? Yeah, do you want to just?
Do you want to introduce it briefly and then go straight into questions? So this paper is an update on the mental health integrated strategy, which was drafted for 2014-19 and was approved. So there's some key themes within the document in terms of the areas that it particularly focuses on. So improving access, strengthening partnership working, starting early in terms of preventative aspects, improving the quality of life for people with mental health problems. So those were some of the key themes that the strategy looked at. It was very much based on the Joint Strategic Needs Assessment, which was undertaken in 2012-13. Following that strategy, there was quite significant additional investment in mental health from the CCG of around 9 million, around a number of specific areas to improve access and community-based services. We have since then seen still some quite significant increases in occupied bed days for mental health, and arising from that, we've undertaken a joint diagnostic of looking at the reason for that high number of occupied bed days, which included a bed audit of all the slum beds on a single day to look at what people were actually being admitted for and why they were still in hospital after so many days. The results of that are provided in the report in terms of some of the key findings that we found from that, but one of the most significant issues was the significant length of stay and barriers to discharge, whereas I think previously we thought that there's a significant issue around admissions, but it would seem that there's more of an issue around length of stay and delayed discharge. The paper also talks about some of the planks of the adult mental health model that have been implemented in terms of community-based provision, and it gives a brief update on some of the key work streams around improving access to psychological therapies, dementia, early intervention, and some of the key services that have been taken forward through the investment that we had. And then there's a section around the next steps in terms of areas that we need to focus on going forward, including how we further push forward personalisation, employment, daycare, the work around discharge, and refocusing the offer from the voluntary sector to meet some of the needs that we've now identified through the diagnostic and the refresh that we're doing of the the action plan and the strategy. So that's kind of a kind of broad overview and introduction, but happy to take any specific questions on the paper.
I've got a particular interest in supported housing, so I thought I'd focus on that part of the report. So I'm quite interested to see that this clearly seems to be causing you quite a lot of problems, that you haven't got appropriate housing. Is there, has there in the past been a sort of a pathway, and is it not working, or has that not ever been developed in Croydon in terms of sort of step down and a variety of different types of housing support and supported housing?
So I may need to draw on support from my colleagues from the council here. In terms of
I'm going to have to look over to Pratima.
Yeah, but just before we do that, so we have actually, as a result of the diagnostic, we have set up a joint programme board, and Pratima is a member of that board as well, and with housing colleagues to start to work through what else it is we need to do in terms of providing more flexibility. But maybe, Pratima, you can say a bit more about some of the things that we're looking at.
Yes, we're quite successful around providing supported housing for people with mental ill health in Croydon. Actually, our numbers are quite high. We've got quite a number of people not living in residential care, which is distinctly different to people with learning disabilities, actually, where we have a large number of people living in residential care, and we want to change that. I think the issue here is not so much just about the pathway around step down in, people live. It might be that people living who have been admitted into hospital, they haven't, which they're now working on, they haven't got the sort of acute sort of targeting around their housing needs. We're not perhaps looking at that holistically when people are admitted. So, because we're looking at their health and care, mental care, health needs. So actually, when their tenancies slip or something dreadful happens around their accommodation, we haven't actually done anything to prevent that. And so people then end up staying longer in hospital because they've actually lost the accommodation they previously had. So that's what focus piece of work we're doing now around pathways and making sure that our gateway colleagues are helping us through the particular project they've got around homelessness, helping vulnerable people remain in their tenancies. Having said that, we continuously develop our supported housing to meet the changing needs. Where we've got a bit of a lack of supply is around people with more high mental health needs. So that's what we're working with one of our local housing associations to provide capacity. And I can't remember how many, but it's about a dozen new units to be developed for people with more complex mental health needs, targeted at that particular cohort of people who are stuck in hospital.
So a lot of it is an issue about people needing a home as opposed to supported housing when they come out, or is it a home plus floating support to help them maintain the tenancy as well? As a mixture of those?
When we say supported housing, that is a home. That's supported housing is a rented tenancy approach for people rather than going into residential. So they have a tenancy, they usually have a flat or a room in a shared accommodation.
I've worked housing a lot. I am aware of the definition. I was just clarifying whether, because the supported housing where you have a building that is dedicated to supported housing, where support is on site, and then there is the alternative version where somebody has a home in maybe a general needs block or anywhere, and floating support is provided to them where they are. So I was trying to clarify whether the problem was a shortage of the sort of the more fixed type of accommodation, or whether the issue was primarily that people needed a home and maybe they might need floating support, and that it was more a sort of a homelessness issue, because sort of the implication, it says including supported accommodation, and so I wasn't sure and that seemed to be slightly different to your answer. So I was just trying to clarify, given that it seems to be such an important issue, and you've identified, discharging, it seems to be a key problem. It seems to be getting to the bottom of this is fundamental to resolving some of your issues.
So really, we don't have an issue about our capacity around providing floating support to people who are living in general tenancy or in the community. It is around the capacity where supported housing units for people with higher mental health needs.
And is there also an issue about people losing their home in ways where they could actually be prevented first if they were getting the right support in the right place where they were living?
That's exactly so, and that's where we need to get in there earlier and look at people holistically rather than just the care needs. And that's what we're doing.
Yeah. We do need to be clear, though, that whilst there has always been difficulty in discharging medically fit people from these services, this is an issue that has arisen over the last 18 months to significant levels. So we're talking about in excess, I think it's 122 people that are medically fit and have been medically fit for some time but aren't able to be discharged. We will clarify the numbers, but they are significant, and the pressure that is causing in mental health services equates to just under £3 million.
I'm just trying to clarify again some of the statements. Had any of them lost homes while they were in care because someone on the line either housing benefit wasn't paid or the length of time they were in meant that it ran out and nobody thought that actually it may be cheaper to keep that accommodation going rather than starting all over again because we just didn't have the systems in place? And if that is the case, and I'm sort of seeing some nods, are there any current people at risk in that very scenario because we still don't have a procedure in place? So I'm just trying to clarify because obviously there's some people in the private rented sector where some landlords may be quite happy in some cases to let people go out, but I'm assuming the council and the social housing sector that sometimes people, I know from my own experience, sometimes people just haven't filled forms in and the rents of housing benefit ran out and the whole system has trundled through only to find that they're in a mental health somewhere because they've gone to another part of the country, got ill and gone into the system there, and it just hasn't filtered back to the landlord. So I'd be quite interested to know whether people are losing social tenancies at the moment or care home tenancies at the moment.
So this board that's been set up to tackle this is quite new. So we're sharing the information and intelligence that's come out of the bed audit that was done. So the early sort of signs from that we've been looking at, anonymised data, is that actually people have lost their tenancies, whether they're social housing or private rented, as a result of perhaps not the right intervention earlier, that's what we're sorting immediately as one of our, through our gateway services. They've actually assigned 2 coordinators to work dedicated to this cohort of people, where we know that we still need the intelligence from SLAM to target that work.
Absolutely, and one of the, as you can imagine, we've got a whole series of actions around this, and one of the key actions is ensuring that as soon as somebody is admitted, that the staff with appropriate colleagues in other services are looking at discharge. What's the discharge plan? What does it mean in terms of their current home or a future home for them? So that's flagged up right at the very beginning, as opposed to when they're looking at discharge for that individual, and it's clearly far too late. So I know that sounds as though that should have happened. It hasn't happened, and clearly it's a significant, has had a significant impact on these services, and of course, much more importantly, the lives of the people that it's affected.
Can I just ask whether an assessment has been done of those organisations that are in the social housing sector, you know, to say, listen, we've just done an audit and there's about 15 or 20 of your people who have fallen through the cracks and some have lost their housing through no fault of their own because they've been in their health situation. Whether, you know, cases can be made to say, you know, can we prioritise those ones? Because it does seem very unfair on the very people who are the most vulnerable when they're not maybe in control of what's going on in their life to end up in this scenario, because it can't be good for them in terms of their mental health recovery to be in a place where they can't have permanent, because home is a home, and some of them are probably quite distressed about losing whatever they had. It does seem to be, to me, from a personal perspective, that this is actually quite a big issue, and it's something that needs to be quite a high priority overall.
So SLAM have also appointed some additional housing support within the services that they provide, actually, which clearly needs to work very closely with the council service. And they did recently hold a workshop with providers to start to look at some of the issues. But it's really important that in terms of the next level of granularity that we get to in the subgroup, that we start to really get down to that kind of individual level to look at people's experience and what things need to be done differently with some of the providers to prevent these things from recurring.
Same kind of topic. So are there any barriers in terms of the regulations on when housing benefit can be paid, for instance, if someone is a long-term patient? Is it 2 weeks before it drops down? So this is where our gateway services, you know, we'd be needing to use our discretionary housing budget to, such as it is, to support those people so that they don't lose their tenancies. I mean, is there also situations where people are actually, you know, own their properties, albeit with a mortgage, where they're losing their homes, you know, because they're not maintaining their mortgage payments because they're ill?
Yeah, so I think that's some of the detail that we need to work through. So as Fatima said, we have got gateway workers now working with us on this work stream. So I think, you know, it will be important to really understand what are some of the factors around benefits that are also impacting on this, and how can we mitigate some of the issues that we're finding.
I think Rachel had something that she wanted to come in on earlier. I don't know.
Just saying in relation to the whole thing around pathways and how we're using it. We are on an early development. The focus, of course, at the moment is around bed days and acute, but actually a very important part about this is to ensure that people don't get to that stage 2. So I think that while it is important to kind of look at the high level, it's also looking about how we ensure that there's interventions at different scales too. And I think that's part, is that one of the things that always concerns me, and, you know, quite rightly, we do focus on the acute side and people with chronic and long-term enduring mental health within acute sector, but actually people with enduring long-term mental health can live with the right kind of support within the community as well. So I think the thing is that there is issue about primary as well. So, I think that actually in terms of the data, use the term granularity, it's about, you know, are we seeing anything kind of like different now than we did before? So there's quite a lot of information. This is, to me, high level, is actually as it develops, I would imagine that scrutiny would invite the information to come back so you can hear the story. Quite a lot of this is narrative, where you hear or have experience in friends and family or yourself, the stories about what happens. To do this in a systematic, strategic way, we need to find out what is happening to the community of Croydon, not just 1 or 2 individuals, to see if there's a trend, to see if there's a pattern, to see if there's people who are more vulnerable, different parts around this. And I think this is part of the story that we're developing. The evidence-based story around data, backed up with people's anecdote, but actually about how we, as a health and care economy, can actually improve the health and well-being of people with mental health.
The housing issue is really important. I just want to move away from it, though. My overall impression when reading this report was a lot of funding had gone in. We still have a problem with long stays, as it were. That's the key problem. Then lots of things have been reconfigured to try to tackle the problem. But what wasn't clear from the report was whether the reconfiguration seemed to be having much effect. And when I came to the tables at the end, it would appear that there's quite a lot that we're still not meeting. You know, there's quite a lot of yellow on there. We're not meeting targets. So from the overall impression of the report, I was just unclear whether, yes, we've identified a problem, we've reconfigured a lot, but is the reconfiguration having the desired impact? And when are we going to measure that to see whether, you know, it is having the desired effect?
If I just pick up the adult mental health model, and then I'm sure Stephen will come in. What we said at the beginning was what we'd seen. So we've implemented significant tranches of the adult mental health model, and that's about improving, as Rachel reflected, what we've absolutely got to do is improve services in the community and in primary care to support people to stay at home and to effectively manage their condition. And we've seen a decrease in admissions, but an increase in length of stay because of the reasons that we've outlined. So I would argue that the services, although they're not fully implemented yet, and there's clearly more that we need to do with SLAM, actually we are seeing admissions reducing.
Yeah, so certainly a lot of our focus has been on community investment, so all the way from primary care through to the way that the home treatment crisis team operates, make sure that is more effective, looking at easier access for GPs to get advice as well on patients, and we're also looking at what funding sources there might be through primary care funding as well to try and do more in primary care. So I think there's a lot more we can certainly do. I suppose one of the significant issues for us, though, is that as long as we've got this issue around pressure on occupied bed days and the resultant cost pressure that causes, that means that given our financial constraints, it means there's less that we can do in terms of the community investment side and taking that forward to a next stage. So it is potentially a bit of a vicious circle. If we don't tackle the OBD issue, then we don't free up the resources to invest in the community.
Two more specific questions on the report itself. Thank you for those responses. The first was when you did page 75, summary of findings from the inpatient diagnostic. Bullet point 2 says 1/3 of patients had a physical health problem or problematic substance and alcohol issue. Is that in line with the rest of the country, or is that particularly high, and is that one of the reasons people are staying longer? And but I just wasn't clear whether that was something that was specific to Croydon or.
I think that's probably a general issue. Actually, I think in a lot of parts of the country there do tend to be physical health problems, people with mental health conditions, and which need to be addressed in an integrated way in terms of how we integrate mental health with some of our other services. And substance misuse clearly is also often an issue, and dual diagnosis services are therefore quite key. And part of the work we're doing with public health is to look at what is the extent of that in Croydon, and what else do we need to do around some of those areas? You might want to add to that, Rachel.
Just backing that up in terms of, is we know with people who experience long-term physical health problems are significantly more likely to experience low-level and higher-level mental ill health issues, kind of like depending on the nature of the physicality, physical issues. We also know that there is a very strong link around mental ill health and substance and alcohol misuse in terms of the dual diagnosis. And actually, in relation to this, you know, very early on in my career, kind of like the debate, you know, does the substance misuse come before the alcohol, the mental ill health, or does the mental ill health come before the substance misuse? And actually, this is the debate around this as well, is that there is kind of linked around supporting how people come into the services. And often people are kind of presenting with substance or alcohol issues when actually it really is a severe and enduring mental ill health problem, or vice versa. So, and actually that is about how presenting as well. So we need to kind of unpack this, see who's presenting and how, what route they come in, and that also allows kind of like the support to enable people to self-support and self-care, which is really important too.
Say that what I have noticed in a centre where I'm involved is that we are seeing now, which we never had before, people roughly sleeping at the side of the building, and in the morning there's bottles and there's needle, you know, stuff around, and that's a new factor in that area. So we are seeing more people sleeping rough with those sorts of issues around them.
Sorry, my final specific point was just on page 76. It said promoting recovery teams, and it said that has been reconfigured into 4 teams to align with the GP networks. But I understand that the GP networks has 6 teams. Is that a resource issue, that there's just not enough people to cover the 6 GP networks, or was there some other reason behind that?
No, I think it was just it just seemed a sensible way to cover the 6 teams by having the 4 promotion recovery teams. So they actually cover the 6, and it was just based on the caseload for each of the networks and what we thought would work in terms of having enough teams, but would be able to have the sufficient reach across the 6 networks. So that's basically how it was configured.
Regarding the action plan itself and what's written in the outcome measures column, there's some very specific ones, such as on page 82, where the outcome measure is to reduce attendance at A&E. So I'm assuming that there's a set of figures behind that. But then there are other ones whereby I was looking at the one we've just been talking about, where the aim is to develop a housing and housing-related support action plan. The outcome measure is to increase access to mental health services those service users living in emergency accommodation. Now, I'm not entirely certain that the outcome measures, some cases are sort of like very high-level aims rather than outcome measures. This column seems to be very inconsistently filled in with very high-level stuff, and then some other ones that are low-level. What's happening to this column? Will it be reviewed, or...?
Yeah, I think that's a fair point, actually. So we are reviewing this action plan in terms of, well, first of all, in terms of what we've learnt from diagnostics. That now needs to feature in here as well. And I think we do need to think a bit more about the metrics for each of the areas to make sure we've got some consistency. So the mental health strategy group is going to be doing some work to make sure we've got tighter metrics for all the different areas.
Isn't a question, so it's just, I just want to relate an experience. And my husband's Israeli, he comes from a kibbutz, and one of his friends has quite serious mental health problems, and he's a member of the kibbutz. And the thing that happens to him that just doesn't happen is whenever he comes out of hospital, he goes back to his home, because the home is always there for him. It's his flat, it's his house. But also the kibbutz always ensures that he has work. Doesn't necessarily like all the jobs, but he's always got work. And I just think it's the thing that is almost the ideal situation, that somebody comes out back into a home that they had and work is there. And it is such a shame that it's such a struggle to provide that generally.
And I have to say, Councillor, the welfare changes won't make it any easier.
Transformation of CAMS. I think there's a real expectation that waiting times for diagnosis and treatment will have come down somewhat. Have you got any up-to-date figures on that? I mean, what are your expectations in terms of percentages?
I haven't got the figures off the top of my head, but we could certainly provide those separately. So we have seen quite a significant reduction in terms of the waiting times, and we're continuing to work on that, but we could provide the data separately. That would be helpful.
Brilliant, that sounds good. And a word on the substance and alcohol misuse support services. I did hear actually that they're not open to refugees and asylum seekers. Have you got any information on that at all? I've heard that they're not actually eligible to access them.
Give us details and we'll investigate that. I mean, certainly that's the first I've heard that in relation to that, literally the first term I've heard that. Keep my kind of ears to the ground. And certainly within the next month, we're going to be relaunching the Substance Use Partnership, kind of looking around alcohol and drugs, not just as commissioners, but commissioners and providers working around supporting it, linking into the mental health service as well. I am genuinely surprised if you can email me the details around that, and you know, kind of where we're hearing around this, because we're working very closely with certainly our providers around alcohol and well, it's kind of like yes, okay, thank you, that'd be good.
Can I just pick up on the figures for CAMS referrals and waiting times? I seem to recall from previous discussions we've had on this that there's a difference between assessment and diagnosis. And I think what would be quite helpful is to have that distinguished in you know, the figures that we're given, so that because obviously until people have a diagnosis, they can't start accessing, for instance, support from schools and such like. So I think that would be quite helpful for us as a committee to be able to see that difference. Has anybody else got any other questions? Sorry, I'm starting to fade. Well, thank you. I think you're free to go, should you wish. Darren, you've given us a written report. Did you want to add anything to that, or give us any recent information about anything?
Well, we engaged with about 2,000 people on their experiences of GP services, and a report we recently published actually resonates with a couple of national reports as well. And although overall services are actually quite good, there are some concerns on receptionists kind of stepping into the clinical domain to give test results, triage for appointments, that kind of thing. And there is the rise of the telephone triage by GPs, whereby you'll phone to make your appointment, half an hour later a GP will phone you back and try to diagnose you over the phone, if you like. So care is becoming less personal over time. There's plenty of evidence for that. And while personal care doesn't matter to a lot of people, you know, it still does matter to quite a few people. You know, continuity of care and all that kind of thing. So that's the direction of travel. What we can do about it, I've got no idea. You know, it depends on resources. But, yeah.
Just linked into that, and I kind of in relation, I've worked with Health Watch kind of like before within NERM as well. Evidence shows in terms of the triaging using the GPs, it works really well for patients. It actually cuts down the waiting time around this. It reduces the anxiety of some people, so they actually have somebody on the end of the telephone rather than waiting. So actually, you know, is that certainly the kind of conversations that I've had with people kind of like elsewhere, not within Health Watch hat, is that people value that because at least they're having engagement with a clinical person on the day of their concern. I think the frustration for some people can be that actually, because of course it's you know, kind of they are being triaged by a clinician, is that they may not necessarily get to see the clinician on the day they want to. That doesn't necessarily mean that they haven't actually had a kind of like clinical opinion. And actually, certainly the evidence shows it is a good way of using clinical, and it means that for most people it will provide alleviation. Certainly, we probably do need to look at is the triaging, making sure we're seeing the people who are most at need. But generally, evidence suggests it is.
I mean, I actually ask for I have a regular occurrence, and I phone up and say, I've got it again, can the doctor ring me? Doctor rings, I get a prescription, we all know the score. They do a test just to check I was right. Hey presto, job done.
And the role of the expert patient around that, some people know their own conditions and symptoms very, very well. The other thing as well is that, you know, kind of people who aren't familiar with that, self-diagnose, kind of, and actually that is kind of like, you know, kind of like risk as well. So actually the triage is just that, but it's a good interventions for the people who have, you know, certain things. So I'm saying is that I hear the caution around Health Watch, but actually it's a significant improvement on waiting a very long time, kind of like to actually get any contact with clinical people.
Thanks. I mean, I'd also echo Kathy's. We actually have the same GP practice, but yeah, there are occasions when I need to phone up and say, you know, this is what I need, and it generally works well. So, shall we go back to our conclusions and recommendations on our agenda items this evening? You're welcome to stay, or you can go. Yes, yeah. Okay, let's do the JOSCs.
It's not walk, it's jog.
Yeah. Yeah.
It's on screen.
Yeah.
Makes us feel a lot better in here after 2 hours.
Yes, so there's a number of JOSCs ongoing. So the South West London JOSC, I reported last time that we'd had a meeting where we didn't really get much in the way of anything other than very high-level information about the STP. We are trying to find a date for a further meeting. It's proving somewhat difficult, given we've got members from 6 boroughs to try and accommodate. And at this present moment, we haven't got a date, but we also don't know whether NHS England will have sent anything back to the STP, or on the STP, so we don't know whether there'll be any more information. But we were offered a confidential briefing by the consortium, I suppose I'll call it, and it would be, I think, quite helpful to get that. But whether we can find a date this side of Christmas, I'm not sure at this point in time. On the STPs, there's a proposal to set up a pan-London JOSC, and several, I think it's at least 3 of, is it 4 or 5 JOSCs in London? 4. I think there's 3 of them certainly have committed to that, and there's a meeting being held on the 24th of November, which I'm able to go to. So hopefully we might have a bit more of a strategy maybe across London rather than looking at it in little pockets. The South East London JOSC, which was looking at the SLAM place of safety, that hasn't met since the last meeting, but I also haven't seen that the agreement has been signed between the boroughs about the I've forgotten what they're called, is it AMPs, assessing, it's the mental health practitioners who assess someone when they're picked up by the police and taken to the place of safety. I don't know whether Barbara knows whether that's been signed or not.
I don't know whether it's been signed, but I do know there were differing views from the authorities that were involved. We would be very positive on wanting the agreement to be signed. There is at least one authority who is less keen on signing, and I don't yet know whether we've reached any resolution.
The JOSC had said that they weren't happy for the central place of safety to open until that agreement had been signed. So I assume that we're still in the same situation, having not heard anything different. I think that's all the JOSC information. So if we want to just have a quick run back through our recommendations and conclusions. So if we cast our minds back to the overview of the care home market as a starting point, I mean, I think throughout every item this evening we've had concerns about whether OBC is going to deliver, and I know that's not what the meeting was about, but it does seem to be an integral part of it, yeah.
They're all relying on it.
Yeah. I think there's potential concern about, you know, a shortage of nursing beds rather than general care home beds, and also concerns that the costs may rise because of that shortage and because of the other pressures on the system. And we did hear a bit about, you know, the council stroke CCG provision for providing more nursing beds, and I think I would suggest that a recommendation might be that, you know, the council actively looks at that as a way of addressing that shortage and preventing the costs from rising, whether that's for, you know, on the basis of their step-down beds or whatever. But it does seem to link into lots of other things that are going on, including the draft STP.
The comment I would make is that I think it's in the council, but it's in the council's interest to intervene where the market is failing, and if the market is failing to provide that certain type of accommodation, either because there's been a bigger growth than expected, it takes a while for the market to deliver, or just because it's not something the market is currently interested in, I think it's something that the authorities should actively consider. And I'll be very keen that, I'm not saying that we should